I'm a medical doctor, graduated from Turkey, and yeah, I've been doing research ever since, and it's been 4 years. Yep.
Thanks so much for joining us, Brancel.
So I have 2 cases. I'm not sure which one to present. I have one kind of complicated case with multiple familial cancer predispositions, and one more like an easy case. And I don't know which one to pick, but I think I'll pick the easy one. And if we have kind of time, we can talk about the second one.
Yeah, that sounds perfect. Let's plan on getting through one case. If it happens that we move through the case fairly quickly, then we can always squeeze in a second case. Before you get into the case, Brancel, I'll have Kaner introduce himself as well. And then we can get our whiteboard up and get started.
Hello, everybody. I'm Kaner Saygin. I'm one of the second-year Heme fellows at University of Chicago, and my clinical and research interest is in leukemias and myeloid neoplasms as well. So nice to be with you all.
Yeah, it's been my pleasure to get a chance to work with Kaner so closely over the last year and a half or so since he's joined U of C. So give me just one moment. I'm going to go ahead and make Madeline our a co-host so she can share her screen. And then Brancel, have you presented to us in the past on CP?
I think this is the first time. This is the first time I'm presenting.
So what we'll do is we will have you kind of present the case to us in aliquots. Typically, in the first aliquot, we'll get through the HPI and then potentially, if appropriate, the past medical history as well. We'll pause there, let myself and Kaner kind of take a stab at what we think may be going on and what additional workup is necessary. We'll then have you present an aliquot with past history and exam findings. Again, we'll take a pause. The third aliquot will typically kind of go through basic laboratory results. And then depending on the case, either in a fourth or a fifth aliquot, we can then kind of have the final piece of diagnostic information just before the final diagnosis is made. So yeah, I will mute myself and I'll let you start telling us about the case.
So we have a 52-year-old male presented with thrombocytosis. So he doesn't have a previous health record. So this is the first time he's presenting, and he's relatively healthy. He doesn't have his only complaint was exercise intolerance and shortness of breath. He was complaining about shortness of breath for the past couple of years, but other than that, he doesn't have any medical history. He doesn't have any comorbid conditions. He's not using any medication, and yeah, he doesn't have any allergies. So to start with, those are the basics of this patient.
Great. And Brancel, just to make sure we're not missing anything else, any constitutional symptoms, fevers, chills, night sweats, anything like that the patient may have?
He doesn't have fever. He doesn't have chills. No night sweats. Only complaint was fatigue and shortness of breath and exercise intolerance. Those are the only complaints. But he didn't mention about fever, chills, night sweats, or early satiety. Those kind of symptoms.
Great. Thank you. Kaner, why don't you tell us a little bit or walk us through what you think about when you see or hear about a patient with thrombocytosis and kind of what your diagnostic process and approach is to that in terms of using thrombocytosis as our initial guiding point and kind of where to go from there.
Sure thing. So as I understand, thrombocytosis is the only problem, right? For now, we're just focusing on that. It seems like this is a relatively healthy person otherwise. So when I see thrombocytosis, which by the way is a very common consult for hematology, either in the clinic or in the inpatient side, obviously the main categories you think are whether it is reactive, which in most cases it will be, or it is a primary problem of the bone marrow. So the reactive causes can literally be secondary to anything, but most common cause of thrombocytosis would be iron deficiency anemia. So especially here, someone comes with shortness of breath, and which might be attributable to anemia if they are anemic. So when I see thrombocytosis, I reflexively include iron studies in my evaluation. Other than that, any infectious inflammatory cause can cause thrombocytosis for sure. So that's another big box. Certainly when people are admitted, septic, a lot of things going on, their blood counts can go either way, up or down. And reactive thrombocytosis secondary to infection or inflammation is a big category. And obviously, as hematologists, we always worry about primary bone marrow problems if there's an excessive production of platelets as part of a myeloproliferative neoplasm or any other proliferative process of the bone marrow is something that we would worry about. So these are my big box categories.
Yeah, Kaner, I love that. And I'd say if there's one point I'd like everyone in the audience to walk away with today is that the most common cause of thrombocytosis are secondary or reactive causes. And like Kaner very elegantly laid out, and within that reactive bucket, things that are going to cause inflammation, such as infection, sometimes rheumatologic conditions, sepsis, other sorts of kind of cytokine-driven states, you can certainly get thrombocytosis. And especially on the inpatient side, I think one of the rules of thumb in general is if patients are admitted to the hospital and they have thrombocytosis, typically if there are acute things that are going on that are reactive and can potentially explain the thrombocytosis, searching for a primary cause of that thrombocytosis is usually low yield. If a patient is improving and their thrombocytosis isn't really improving, that's really when on the inpatient side, we start thinking about, do we need to do more of a workup for an underlying bone marrow disorder? And Barancel, one thing I may have missed is this patient presenting in the clinic or in the ER, or what's the setting that he's presenting to us to?
This patient presents for clinic.
Okay, wonderful. So, this is a patient who otherwise is feeling relatively well. So that's something that would make me think a little bit more about, is there a primary hematologic issue that's driving the thrombocytosis? I'd want to do a good physical exam, which we'll get here soon, particularly looking for the presence of splenomegaly. And other things that I'd be really looking at on exam is seeing, for example, whether the patient had any flushing or redness in their face. And these are the sorts of things that can be maybe clues or tip-offs to this thrombocytosis being related to a family of diseases called myeloproliferative neoplasms, or MPNs for short. The three most common types of MPNs are polycythemia vera, essential thrombocytosis, or ET, and primary myelofibrosis, or PMF. Another MPN that can cause thrombocytosis is what we refer to as CML, or chronic myeloid leukemia. That is typified by the presence of a fusion protein called BCR-ABL. So on exam, those would be the things I'd be really interested in. The exercise intolerance and shortness of breath concern me quite a bit, given that this is a 52-year-old man and seems to be in relatively good health. Common things being common, the things I'd want to rule out right out of the gate are cardiac etiologies and then pulmonary etiologies. Particularly thrombotic issues, as those can certainly be present in patients with an elevated platelet count. So with that, Barancel, why don't we have you give us the next block of information?
I think one more. Someone wrote this in the chat, splenomegaly. That's a very important one, so we should include that in there too. Yeah.
For this patient, I don't have the all labs, but I have so this patient presents after. So this part's not exactly clear because patient gave two different histories, kind of like he said, like he didn't see his PCP first, but he said like he went to his PCP, then he got his like CBC results, and then thrombocytosis was found. So I don't have the numbers, but based on the history, I know like what is low or what is high. So just I think. And also, patient looks kind of like whitish, like he has pallor. And for he looks generally well. He has pallor, and let me find the thing. Yeah. No fevers, no chills, no night sweats, hepatitis good without weight loss, no mouth sores, and no cough, no shortness. He has shortness of breath only when he exercises, and no visual changes, no headache history, or no vasomotor like complaints, no focal numbness, weaknesses, or tingling. And respiratory system, it was normal, like no cough or no cough, no chest pain, or tachypnea or palpitation. So basically, this patient presents with normal physical findings, and this patient doesn't have splenomegaly on physical examination.
Sorry, can you say that? Did you say he does or doesn't have?
He doesn't have.
Oh, does not.
He does not have. Yeah.
Okay. And do you happen to know whether an oxygen saturation was checked or not, and if yes, what it was?
It was checked at the beginning. Everything was normal except heart rate, and heart rate was 57. Yeah, which is still normal, but on the lower range. Yeah.
Great.
I believe saturation was not 95.
So, Kenner, does this physical exam appreciably change kind of what's on your mind or what's on your differential in a significant way?
So I think as hematologists, we are mostly lab people. So far, since there's no splenomegaly, I don't know if this swayed me in either direction. I mean, lack of splenomegaly is obviously something that we care about. Like most myeloproliferative neoplasms present with a splenomegaly, but its absence or inability to palpate it on exam doesn't necessarily rule out splenomegaly. Because normal spleen is 12 centimeters, and for it to be palpable, it has to come to like 14 or above, probably roughly. So, and absence of splenomegaly doesn't rule out primary bone marrow process. So that's an important piece. The pallor on exam that is mentioned might suggest that he might also be anemic, which is important because then you're dealing with more than one cell line problem of the CBC. So that's something we have to find out. And I think that's all I have so far.
No, that's great, Kenner. A couple other points that I'll add. So when talking about pallor, so pallor that you can see in the face or conjunctival pallor, anemia has to be pretty significant for that. Typically we think of like a hemoglobin of at least 7 or 8. Sometimes if you can appreciate pallor of the palms, then it's an even lower hemoglobin, a hemoglobin of 4 or 5. Someone in the chat mentioned point of care ultrasound for splenomegaly. And I'm going to push back on that a little bit. So in many ways, point of care ultrasound is quite effective and helpful. Finding splenomegaly alone doesn't do much for us when working up thrombocytosis and thinking about splenomegaly specifically. It really means something if splenomegaly is large enough to where the spleen can be palpated on physical exam. So really, if splenomegaly is clinically detectable on exam, that's typically when we think of it as being large enough to cause symptoms such as early satiety because it's pressing on the stomach, abdominal bloating, fullness. So an ultrasound of the right upper, of the left upper quadrant, sorry, or a POCUS, may tell you that this patient has splenomegaly, but I don't think it does much for us clinically. So one of the few situations where I'd say POCUS is not very helpful for us. So with that, why don't we get into labs?
So first we have a CBC with differentials, but unfortunately I don't have the results. I only have what like hey, what is high or low like in the history. So white blood cell count is normal, hemoglobin is low, it was 9, and platelet count is 600. It's the I think I have that 650. Yeah, 650.
And Barnsell, do you happen to have maybe like a rough sense of the differential, even if you don't have the exact numbers by any chance for the white blood cell count?
Everything was normal, and any I don't remember any monocytosis or any like neutropenia. Okay, and yeah, differentials it was normal. Or like any atypical cells on the peripheral blood.
Did you say there were sickle cells?
Atypical.
Oh, no atypical cells.
Yeah. Yeah.
Okay. Do you have an MCV?
I don't have it. I don't have that in the history. But based on first PCP appointment, he is diagnosed. He's diagnosed as iron deficiency. Like the PCP said, he has iron deficiency, so they start iron, and then things like develop into like other things. So we'll mention about that part. So ferritin is low, and hemoglobin is it was 9. So after these findings, they start iron supplementation. But after iron supplementation, thrombocytosis doesn't change. It still stays. But iron supplementation helps with the anemia. And then he has workup for gastrointestinal bleeding. On that part, he doesn't have any complex hematochezia or no like no blood in the gastrointestinal system. Yeah.
So
his kidney function. Yeah.
He got scopes, you mean? EGD colonoscopy? When you said he got evaluation?
I can see sigmoidoscopy. Yeah.
Okay, so they were fine.
Yeah.
So maybe for the sake of the audience, and just to make sure that we're on the same path so far and the same track, I'm gonna just take a moment to summarize what we know about this patient, and then I'll let Kaner kind of add where he thinks the diagnostic workup needs to go from here. So this is a gentleman, 52-year-old, who had symptoms of exercise intolerance and shortness of breath, found to have iron deficiency anemia along with a thrombocytosis, was started on iron supplementation, underwent a GI workup that was unrevealing for a source of blood loss. With iron supplementation, his anemia improved to some extent. His thrombocytosis persisted, and he has now has he been referred to hematology at this point, Barnsell?
Yeah.
Yeah, and has now been referred to the hematology clinic. So it sounds like some component of iron deficiency anemia, but his thrombocytosis persists despite some improvement of this anemia. And that's very important because thrombocytosis and iron deficiency anemia tend to travel together. But when someone's iron deficiency anemia is corrected, you typically expect their thrombocytosis to correct as well. Kaner, what would you be looking to do for this patient next? And what's kind of on your mind in terms of differential at this point?
I think the most important thing when I see these patients is, and this is exactly the time that they are referred. Someone tries to replete their iron and it's repleted, but the things don't normalize, so they are referred to a hematologist. So the first thing I want to know is, when did the thrombocytosis start? Did this patient have a prior CBC 6 months ago, a year ago? Do I have an older CBC to see how long he's been having this thrombocytosis? That would be something important. If he has had that for several years, that might suggest a more chronic problem versus if it's recent, it might be more acute or reactive potentially. So that's one thing in the history I would love to see. And the other thing I like to do is when there are more than one cell line abnormality, I like to work them up individually too. So here there's someone with anemia, initially thought to be iron deficiency anemia, and now presumably iron is nicely repleted. So I would want to see a more detailed anemia workup, like the retic count, hemolysis workup, all the other vitamins, to make sure that we are thoroughly investigating that. And then, it doesn't seem like so far there's anything reactive in this case. This person doesn't have any history of autoimmune disease or any infections as far as we can see. So if the anemia workup is inconclusive and if this thrombocytosis is chronic, then he might deserve some evaluation for a bone marrow problem.
Yeah, that's exactly what happens. And previous CBC results, it shows high platelet count, around high 60s, and it starts a couple of years ago. 4 years ago. So he always says this high platelet count for the past 4 years. It doesn't go down. It's not really high, but it's like 650. And he has anemia. He was diagnosed with anemia before, and he had gastrointestinal workup, but it was unrevealing. So this is not the first time he's going through the same anemia workup.
And Barancel, do you happen to have any hemolysis labs, a B12 level, a folate level, anything else in terms of the anemia workup, in terms of specific labs?
They were normal. B12 and B12 was normal. MCV was normal, I believe, and I think they checked LDH. That was also normal. We don't have inflammation markers, CRP or ESL. We don't have that. Yeah, and chemistry was normal. So my question in here is, where is the threshold to say that this patient needs a bone marrow biopsy? Because bone marrow biopsy isn't invasive diagnostic method, and when do you say that yes, this patient needs more more evaluation for hematologic oncologies, and we do bone marrow biopsies versus let's just follow up this patient once a year or every 6 months.
Yeah, I mean, I think, I certainly think Kaner and I both have a bias to some extent because we are hematologists. We have a subspecialty bias, and because of that, I think both of our thresholds to perform a bone marrow biopsy is probably lower than maybe the average clinician or anything like that. Some points that I'll make is, in general, if 2 cell lines are abnormal, and after a non-invasive workup, you don't have a good reason for why they're abnormal, I really strongly start considering doing a bone marrow biopsy. And the reason is, Barancel had alluded to this, but the bone marrow biopsy is actually an incredibly low risk procedure. There's virtually no risk associated with it other than pain at the local site where it's performed. And typically with good local anesthesia, there really isn't even much of that. There's no bleeding risk. It's a sterile procedure. There's next to no infection risk. The biggest burden from a risk standpoint is patients are very concerned about it. The procedure itself can make patients quite anxious because it's typically described as a very intensely painful procedure. Most of the time after the procedure is done, the patient will tell us that the pain was very well controlled. Like I said, you can give lots of local anesthetic, and you can give a little anxiolytic too if needed, like lorazepam. So for this patient, if their anemia has not corrected with iron supplementation, and if their thrombocytosis persists, given the fact that they have other normal peripheral markers looking at causes of anemia, my workup tree would take me to a bone marrow biopsy next. And the other thing we think about as hematologists is not just should a patient get a bone marrow biopsy or not, but what tests should be ordered with a bone marrow biopsy. So Kaner, what tests do you think would you be thinking about if we were to say the next step for this patient is a bone marrow biopsy?
Sure. I'll come to that, and along those lines, since now we are thinking there might be a problem in the bone marrow, as we ruled out a lot of reactive or secondary causes here, is that when you look at peripheral smears, for certain myeloproliferative neoplasms, you can see teardrop cells, or you may actually see big platelets or platelets that have granule abnormalities, etc. So the peripheral smear is still very helpful and useful in those decisions. So I would not, I want to emphasize it a little bit. And when we do the bone marrow biopsy for a patient like this, obviously, we want to see the aspirate and the standard Trephine biopsy. It's important to look at the aspirate. Aspirate is like the cytology. So you get the liquid portion of the bone marrow, and then you look at those cells, and it gives you the best way to assess the morphology. It's essentially the peripheral smear of the bone, not the peripheral, but smear of the bone marrow, that aspirate. And it's something that the technician, the bone marrow technician, prepares, makes the smear on the side. And that helps us assess if the cells look normal or abnormal, if there's any dysplasia or not, are the cells looking atypical or not. And also, with that, we make a differential of the composition of different types of cells in the marrow. And the second portion of this morphology assessment is the core biopsy. So after you get your aspirate from the bone marrow, you go in and get hopefully a centimeter core, and that's the tissue, the actual bone marrow tissue. And that it provides very important architecture information, especially for a patient like this. You would want to know if there's fibrosis in the bone marrow, so that with that you can stain for the collagen fibers and score if there's fibrosis. And obviously several bone marrow pathologies can have certain patterns or certain architecture that's important for diagnosis. So that's your tissue piece. And then there are several molecular tests that I would be interested in ordering on this bone marrow aspirate. So first and foremost, we'll do the standard cytogenetics, which is the karyotyping. We count at least 20 cells and look for their metaphase 46 chromosomes to see if there are any big structural chromosomal changes that you can see with your eye. That's the standard cytogenetics. And then one can consider FISH testing here, although I wouldn't probably order it right away because I don't have a diagnosis. So I would just wait to have some more information so that I know what I'm fishing for. But the main thing I want to see are certain molecular mutations, especially for a patient like this. When you run the NGS, you run a broad panel, but in this case, there's thrombocytosis. So we are thinking about Mpns. And that panel should definitely include JAK2, as well as the MPL and CALR mutations, the JAK2, MPL, and CALR, calreticulin. And well, one thing to run on FISH though is BCR-ABL. I forgot to mention that we still need to rule out CML here. So those are my initial thoughts on the bone marrow.
Yeah, and let's use we'll use this as an opportunity to do a little bit of teaching about the test that we order on the bone marrow biopsy, as Kaner very expertly laid out. So when thinking about how can we assess cells on a bone marrow biopsy, what test should be ordered? As Kaner said, karyotyping or cytogenetics is looking at the chromosomes of 20 cells, and typically, to catch an abnormality on karyotyping, it either has to be a large deletion or a large translocation of cells. There has to be lots of material missing or lots of material switched around. To add an additional layer to that, you can do FISH testing. And FISH testing uses probes to look for very specific parts of those chromosomes to either be missing or rearranged or translocated. The big catch with FISH is you have to know what you're looking for. You have to order the specific probe. So for example, if we were looking for BCR-ABL translocation, we have to order that specific FISH probe. And then we get to molecular testing. So looking for molecular mutations within the cells themselves. When talking about myeloproliferative diseases, about 90 to 95% of them will either have a mutation in JAK2, CALR, or MPL, with JAK2 being the most common by far. About 5 to 10% will be what we call triple negative, meaning they don't have a mutation in any of those three genes. Someone in the chat asked, if you test for JAK2 on the peripheral blood and it shows a mutation, can you avoid a bone marrow biopsy? This is going to be my other big teaching point of the day. Absolutely not. So a bone marrow biopsy is essential to make the diagnosis of what specific myeloproliferative neoplasm someone has. It's part of the WHO diagnostic criteria. Just because someone's platelet count is high and they have a JAK2 mutation does not mean that you can say they have essential thrombocytosis. They could still have PV or they could still have PMF. So if there's one, point number one about 30 minutes ago was most thrombocytosis is reactive. Point number two is if you are concerned about a myeloproliferative neoplasm, and even if molecular testing is positive on the peripheral blood, a bone marrow biopsy is necessary to make a diagnosis and confirm it. In practice, there are clinicians who don't get a bone marrow biopsy. There's a very good chance they haven't arrived at the correct diagnosis because they haven't confirmed it with the bone marrow biopsy. So let that be my other big point for the day.
I think one test I forgot to mention is flow. It's very important. Maybe not as much for this one, but the flow cytometry to look at the markers on the cells and also to understand blast percentage and all that.
So we have bone marrow biopsy and molecular testing. We don't have flow cytometry. Bone marrow biopsy shows 50% cellular bone marrow, and every lineage looks normal. There is megakaryocyte hyperplasia in bone marrow biopsy. Critical staining shows 1 out of 3 fibrous staining. And yeah, that's all for bone marrow biopsy. And for molecular testing, this patient is positive for JAK2 V617F mutation. So in this case, we have molecular test plus bone marrow biopsy. And also other things that were sent was BCR negative.
So to confirm, because I think Brancel, we may have missed a couple things as you were reporting them. Grade 1 out of 3 fibrosis, is that correct?
Yeah.
Megakaryocytic hyperplasia. Was there any atypia or abnormal megakaryocytes that were reported?
Based on report.
Okay. And then you said the BCR-ABL FISH testing was negative. Is that correct?
Yes.
And sorry, you had said one other thing about molecular testing. Was JAK2 was tested and it was detected.
Mm-hmm.
So JAK2 and was that the V617F mutation? Okay. Yeah. So detection of the V617F mutation. Okay. Kainer, do you think we have enough to arrive at a diagnosis for this patient?
I'm not so sure, honestly. I'm a little struck by this megakaryocytic morphology. It does seem like this person might have ET, but clearly there's not much fibrosis. But the megakaryocytes in Mpns usually have certain morphologic changes, such as atypia or clustering. So I don't know. This sounds like relatively normal looking megakaryocytes, like just a hyperplasia, which you might even see in a reactive case, right?
Yeah. So this is why getting a bone marrow biopsy is so important to arriving at the final diagnosis and having a group of pathologists that you really trust. Because it's exceptionally hard to differentiate between essential thrombocytosis and primary myelofibrosis on bone marrow biopsy, particularly in the early stages of primary myelofibrosis. So this patient has some degree of fibrosis, grade 1 of 3, but all MPNs can have some degree of fibrosis with them. I think the answer lies in how the megakaryocytes are described. So if megakaryocytic atypia, meaning abnormal looking megakaryocytes, or megakaryocytic clustering, so lots of megakaryocytes clustered together, if those were seen, that would make me worry much more about primary myelofibrosis. If hyperplasia is the predominant feature of the megakaryocytes, so having too many megakaryocytes, that's when I think of ET as being what's at the number 1 part of my differential. So in my mind, I think this patient either has essential thrombocytosis or they have a very early PMF. If I had to put my nickel down on one or the other, I would say I'd be leaning towards essential thrombocytosis just because of how the megakaryocytes are described to us here. The presence of a JAK2 mutation is helpful in that it lets us know that this patient almost certainly has a myeloproliferative neoplasm based on everything else that's going on. But JAK2 mutations are the most common mutation in both ET and in PMF. So from that perspective, the presence of a JAK2 mutation doesn't really help sway our diagnosis one way or the other in that regard. So I guess very reluctantly, I will kind of end up on the side of ET as opposed to PMF, but it almost certainly could be either one.
These are tough ones. Sometimes 2 different pathologies can also give 2 different diagnoses on these. It's quite common that someone diagnoses this with ET and then pathologists in Chicago say this is prefibrotic MF. So, and sometimes, you may not definitively know, which is difficult for hematologists because we have very objective diagnostic criteria. We are not like rheumatology. So I sometimes tease my wife that, you just sit down and think through things and make a diagnosis. For me, it's the pathologist says 20% blast, AML, done. But here in these cases, sometimes over the course of years, it progresses in one direction. And you may actually have more morphology in the marrow to make a diagnosis. But I think at this stage, we're going to say with the presence of JAK2 mutation, it's concerning for an MPN, and the overall morphology is probably supportive of ETES. I wonder what the pathologist wrote, Barancel. Do you have that?
Actually, I checked the pathology report and I realized I will overlook one thing because it doesn't say abnormal. It says there are frequent small clusters observed in megakaryocytes, and at first I thought that was normal, and right now I don't think it is normal after the conversation. Yeah, it says frequent small clusters of megakaryocytes are seen. And another thing, this patient also has other mutations, other commutations. That was also reported. My question is, so for cytoreductive therapy, what is the cutoff for saying that this patient needs some kind of cytoreductive therapy to reduce platelet count?
Barancel, if you don't mind me asking, did the bone marrow biopsy, the final kind of diagnosis, did the pathologist say whether they thought it was essential thrombocytosis versus primary myelofibrosis?
Let me check it in real time just to make sure.
And the reason I ask Barancel that is it's incredibly important. Yeah, ET. Okay. And the reason I asked Barancel that question is because whether or not to cytoreduce, and when I say cytoreduce, I mean start a medication to try and lower the platelet count. Whether or not to do that is very, the decision is very much based on whether someone has ET or not. So the presence of a diagnosis of essential thrombocytosis then should make us ask the question about, do we need to try and drive down the platelet count or cytoreduce? Kaner, what are some of the things that help you make that decision or think about that decision about whether or not we need to drive down the platelet count in ET?
Yeah, so part of that is the clotting risk. So as far as we know, this person doesn't have a history of clotting, but there are certain high-risk features. So the JAK2 is a high-risk feature, and how high the platelet count matters too. Here it is 650. So I think in this case, if you're calling this a JAK2 positive ET, because of the JAK2, I would consider this high risk. There is also age, like about, I think the last one was 60, we consider about 60 now. Older age is associated with high risk too. So I think here what makes me worry about this, clotting would be JAK2.
Yeah, so there's a very helpful scoring system for thrombosis risk in ET. It's called the IPSET, and I've chatted in the link to it. I by no means have it memorized. I don't think any hematologists out there have it memorized, but you just need to know where to find the right resource. So typically for patients that are intermediate risk, which is what this patient's IPSET is, I lean towards cytoreduction if they have a JAK2 mutation, because JAK2 is more associated with thrombotic complications than MPL or CALR, which are the other two common mutations we see. So this is a patient that I would, this patient's relatively young, 52 years old, no prior history of thrombosis, which is reassuring. But our goal should be to try and reduce any sort of thrombotic complications. And given that he's intermediate risk, I would lean towards cytoreduction. The most common ways that we cytoreduce patients with ET is the use of a pill called hydroxyurea, or another drug called interferon. And there are many other, there are several different formulations of interferon. Many physicians will use hydroxyurea initially, and if they're having trouble controlling someone's platelet counts, they will then switch to interferon. But it's actually an area of hot debate whether someone should be treated with interferon right off the bat if they need cytoreduction versus using hydroxyurea alone. Hydroxyurea being an oral pill and interferon being something that needs to be administered via injection. Based on convenience, we typically will start with hydroxyurea and see how a patient tolerates it and goes from there. Someone in the chat asked, should we expect worsening anemia with hydroxyurea? Yes, you will. So hydroxyurea unfortunately lowers all of your blood counts to some extent. So you will expect some degree of worsening of the patient's anemia. And really you want to titrate the hydroxyurea such that you are not lowering their platelet count, their hemoglobin, definitely not down below 8 or so, if you're able to help it. Another medication that can be used is called anagrelide, which is also quite effective at bringing down the platelet count, and it doesn't have the same impact on the other blood counts. So there are times where instead of using hydroxyurea, we'll use anagrelide, particularly if we're running into anemia as being a limiting factor in our cytoreduction. Kaner, what's the talk to the audience a little bit about what we can do to try and cure this patient? What curative therapies are there for MPNs?
Cure is a strong word, and for me, cure usually means doing a bone marrow transplant. Would I do it for this person? No, because if this is truly ET, among all MPNs, it has a favorable prognosis. So these people can actually do very well for several years to decades. So ET is a favorable prognostic category. So I would not transplant this, but in general, cure usually means giving them a new blood system.
Yes. So in this current era, Unfortunately, the only curative therapy we have for myeloproliferative neoplasms is a bone marrow transplant or stem cell transplant, as Kaner mentioned. Referring someone for a transplant is a very high risk intervention. Typically, if we have a conversation about transplant with the patient, the number that we quote is at 1 year after transplant, about 10% of patients will have had severe complications of transplant unrelated to their underlying disease. And oftentimes that complication can lead to death. So there's about a 10% mortality in the first year after transplant. So when you're thinking about a high risk intervention like that, the benefit really has to outweigh the risk. And Kaner very beautifully laid out how for this situation, it's very hard for us to say that the benefit of a transplant outweighs the risk. ET is typically a very indolent moving disease. We would be able to manage this patient with some amount of cytoreduction and also making sure that the patient's iron stores are replete because this is a patient that was also iron deficient. And I think, the hope would be is that this patient would have several years before their disease kind of clinically evolved into something higher risk. So ET with time can evolve to myelofibrosis, what we call a secondary myelofibrosis. So when patients evolve from ET or PV to myelofibrosis, that is another harbinger of their disease progressing, and one other time point where we would think about something like a transplant. But I agree that time is not yet. But unfortunately, in our current day and age, transplant is the only curative therapy we have to offer patients with MPNs. Someone in the chat asked about aspirin or not if you're using cytoreduction. Typically, in my mind, if someone has a low risk of bleeding, it is very safe to start them on aspirin, 81 milligrams. The data for aspirin in this patient population on top of cytoreduction is not very robust. But typically aspirin is a low risk intervention. So I think it can be safely started. And someone else in the chat asked for clarification around what kind of transplant. That is correct. So for MPNs, we would do what's called an allogeneic transplant, meaning the cells are coming from someone else. They're not the patient's own cells, or what we call an auto transplant.
As a general rule of thumb, this might be a confusing thing, different types of transplant. We have auto transplant or allogeneic transplant. So when you're dealing with a stem cell disorder, which MPN is, the problem is in the hematopoietic stem cell, then you need to do an allogeneic transplant because you cannot collect the person's diseased stem cell and give it back to them. But if the problem is not a stem cell disease or a mature cell disease like lymphoma or myeloma, right? They are lymphocyte and plasma cell tumors. The stem cells there, the precursor cells are healthy, allegedly. So then you can collect those cells and then give it back to them after high-dose chemotherapy. So allogeneic transplant for stem cell disorders like MPNs or acute leukemia, and autologous transplant for mature cell problems like the lymphoma, myeloma.
No, very, very nicely put, Kaner. And I love that rule of thumb where if it's a mature disorder of a hematologic malignancy, you can do an auto transplant. If it's a leukemia or a myeloid disorder, we typically do an allogeneic transplant. Someone in the chat asked if someone has acute symptoms like a stroke with ET, is there anything other than hydroxyurea or aspirin to offer patients? So in patients that have had a true thrombosis, whether that be stroke, whether that be a DVT, PE, we typically will do therapeutic anticoagulation for those patients. And we typically will do lifelong therapeutic anticoagulation as long as there's not a contraindication. If there's situations where someone's platelet count is very, very high, you can actually do something called thrombophoresis or platelet phoresis, but it's a very short-term fix. Those platelets will come down for a day or two and then pop right back up. So it's typically you can drive down someone's platelet count quite effectively with cytoreduction like hydroxyurea. So it's not common to have to use platelet phoresis.
think one point we have to make also, when platelet count is so high like that, about 1 million, you can paradoxically bleed rather than clot, or you can have both. Someone can present with a clot with a platelet count about 1 million, but at the same time they might be bleeding. And that bleeding is especially mucocutaneous bleeding. And the reason for that is acquired von Willebrand disease, because when you have very high platelet count, it kind of sequesters and binds the von Willebrand factor. So you will see bleeding much like you would see in von Willebrand disease, which is mucocutaneous. So, depending on the clinical presentation, sometimes you may want to hold off on aspirin or anticoagulation until you drive down platelets less than 1 million or so.
Yeah, and sometimes what we'll do, and to help guide our risk management decisions, is if someone's platelet count is over 1 million, we will check for von Willebrand levels. And if the von Willebrand levels are normal, that lets us know that this patient likely does not have an acquired von Willebrand syndrome. If those levels are low, then we're much more cautious. And like Kaner said, we would really want to try and drive down the platelet count before we started aspirin or anticoagulation if indicated. Brancel, any specific other questions that you wanted to make sure that we addressed? This was a great case and tons of learning. Myeloproliferative neoplasms are something that are, I see a lot of them in my clinic, and I still learn every day about the subtleties when it comes to MPNs. There can be overlaps, people can have both features of ET and PMF. It's a very kind of complex niche within hematology, and one that there's a lot to learn from, and one that it really takes seeing a lot of patients to even get a sense of some degree of comfort level or expertise in taking care of these patients.
I have a couple of questions. This patient has multiple commutations, and those commutations are DNMT3A and ASXL1. So how multiple commutations or having a high number, like high percentage of cells mutated in your blood, would you change your decision algorithm based on that? Would you be more cautious, be on the more cautious side and say, I want to follow up this patient more frequently, or I want to be more aggressive with the treatment?
Yeah, that's a great question. So in general, co-mutations are typically seen with disease that we think of as being at higher risk of having progression. That being said, almost all of the prognostic scores that we have developed that incorporate mutations in MPNs have been developed in PMF, or primary myelofibrosis, and not in PV or ET. ASXL1 is considered a high-risk mutation in patients with PMF. It does not have a clear-cut prognostic role in ET. That being said, the presence of co-mutations definitely makes me a little more nervous that this patient may progress to a secondary myelofibrosis more quickly in the coming years. That would be the main thing. It wouldn't change how I would monitor this patient. I would still check blood counts. Initially, if we were going to start cytoreduction, I would probably check blood counts every 2 weeks or so at first until things stabilize. And then typically I see patients with myeloproliferative diseases that are doing well and on a stable dose of cytoreduction every 3 to 6 months. But yeah, so that would be the thing that worries me is does he have disease that may be at higher risk of progression? Another question that came up in the chat was, is there a way to link in the iron deficiency anemia? And I actually am having a hard time. I think that the iron deficiency anemia was probably a separate process that was going on. We don't think of MPNs by themselves as causing iron deficiency. It sounds like this patient has had a fairly comprehensive GI workup, but I would definitely make sure that if I wouldn't be surprised if this patient down the road had some evidence of like a GI bleed or something like that, and a specific source of blood loss was found. But MPNs, we don't think of as causing iron deficiency in patients.
Yeah, a little bit more bleeding history might have. I don't know, 650 is not a high enough platelet to cause platelet function defects usually, but you know, if in this particular patient, maybe we could have done the platelet function assays and also the von Willebrand levels at diagnosis to try to link the iron deficiency to this. Because remember, in Mpns, things are produced fast. So when things are produced fast, they can be defective. So there might be a qualitative defect, and maybe he is oozing that we couldn't detect.
Given that we are almost at the hour, why don't we have Andrea walk us through the teaching points that she's done such a great job of kind of jotting down as we've gone through this case. And again, a huge thanks to Barunsel for bringing this case to us. Tons of great learning from it. Obviously, it's a topic that's near and dear to both mine and Kenner's hearts. So we really had a blast getting a chance to talk about this case with everyone.
Yeah, that was amazing. Thank you.
Thank you very much. There were a lot of beautiful pairs. So first, when we approach thrombocytosis, we have to know the time and try to compare with previous CBCs. Normally, the majority of cases are secondary or reactive. Common causes are iron deficiency anemia, inflammation, sepsis, rheumatologic disease, whereas primary is not as common, but we think about a primary problem of the bone marrow, and we think about myeloproliferative neoplasm. If the patient is admitted to the hospital and had acute events, you will think that thrombocytosis is more likely to be secondary. Because we look for flushing or redness, because thrombocytopenia is related to myeloproliferative neoplasms like polycythemia vera, essential thrombocytosis, primary myelofibrosis, CML. That is always they always ask about this the fusion gene that is related to CML, that's BCR ABL. And these myeloproliferative neoplasms typically present with neoplasia, with splenomegalia, but for it to be palpated in physical exams, it has to be 14 centimeters. So do not rule out if it's not palpated, and the point of care ultrasound is not helpful. And because the patient had pallor, it's important to know that for a patient to appear with pallor, the hemoglobin has to be 4 or 5, around that level. When we do a bone marrow biopsy, it's something essential for the diagnosis of myeloproliferative neoplasms. And it can be difficult to differentiate secondary versus primary at the beginning of the disease. But the good thing about bone marrow biopsy is the low-risk procedure. The mainly complaint is pain, is sterile, and there is no bleeding. You can just give local anesthesia and lorazepam. The bone marrow biopsy with peripheral comes with a peripheral smear, 1 centimeter of core tissue that can be stained. Normally, you do a standard cytogenetic, that is a karyotype of 20 cells, and you can detect abnormalities, but it has to be a large deletion or a large rearrangement. You can also consider a fish, but you have to order the fish exactly of what you want. Like, so you have to suspect of something for it to be ordered. And then you can do some molecular testing to look for mutations. Something that is always in the boards is that the myelofibrosis is characterized with drop cells. And because this patient had proliferation of megakaryocytes, we've talked about essential thrombocytopenia. And he had JAK2, but JAK2 didn't help us much because it's very common in ET and primary myelofibrosis. This patient had essential thrombocytopenia. It is good because the disease is indolent, but it can evolve to secondary myelofibrosis. And there are some mutations that make it more likely to myelofibrosis, like the one he has. So the treatment is to start to drive down the thrombocytosis. Cytoreduce depending on the risk. You use the IBSA criteria. for example, if this patient has JAK2, that is more related to complications, and also old age is also related to high risk. The cytoreduction of VT is done with hydroxyurea, but it can worsen anemia. There can be interferon, but it has to be given at the hospital, or anagrelate with is in patients with anemia. If the patient you can do therapeutic anticoagulation, and if it's very severe, you can do thrombopheresis, but it will only last a couple of days. If the patient develops a secondary myelofibrosis, you will have to do an allogenic bone marrow transplant. Allogenic bone marrow transplant is used for myeloproliferative neoplasms and leukemia because you can take the stem cells of the patient. You cannot do an auto transplant. Apart from the coagulation prevalence, think about microcutaneous bleeding in TE because the high blood count cause the sequestration of von Willebrand factor. Thank you.
Thanks so much, Andrea, and thanks everyone for joining us. Thanks again to Barancel and Madayena for the case presentation and staying on top of the scribing and making sure we had all of the pertinent information at our fingertips. Enjoy the rest of your day, everyone. And yeah, thanks for joining. Hopefully see everyone again soon.